I'm Dr. Samia Roohi, working as a specialist family medicine in the Department of Internal Medicine in Zulekha Hospital, Sharjah. I started my career as a GP in Zulekha Hospital, and I was working as an ER physician that time. It is way back 15 years back. I served as ER physician for a couple of years, and then I passed my exams from Royal College of General Practitioners, and I was promoted as a specialist family medicine in the same hospital where I'm working now. This journey has been really awesome because I would say that in the same hospital where I start my career, and I have gained a lot of practice and primary care treatment for my dear patients. I have gained a lot of confidence in my in the society around, why the patients trust you and they get confidence in getting treatment with me. So that was one thing which really I found was great. In terms of my continuous professional development, I'm presently into MRCP. It's at the last stage, and also I'm going for the acute medicine MRCP soon. I'll be appearing for the exam next month, inshallah. That's all so far regarding my career. Also, in my hospital, I work as an infection control physician since 2010. I have been having a great role in formulating the policies and protocols in framing the practices, infection control practice protocols. And since then, I'm on move. Let's hope it will continue the journey. Yes, we have some indapamide. It's been claimed to be very good in management of the diabetic hypertension in patients who are diabetes and having this. Like that kind of things, if we these are evidence-based, and there are a lot of literatures which say that indapamide has been found to be successful in treating blood pressure of the patients with. Similarly, one other drug which we don't use it often, we have that is having a very positive effect. We don't give it in routine, but it's also having a positive effect on diabetic hypertension. They are known to reduce the insulin resistance. Some kind of drugs are like that, which we have. We should a little bit deviate from our routine practice and take that also into consideration so that the patient is benefited in 100%. As a primary care physician, though I don't see many of the pregnant females, but if patient is having an pre-existing hypertension, we always advise them that once they get pregnant, they should stop it. I personally prefer to give beta blocker labetalol to them unless and until they are asthmatic or because this they can extend in the puerperium also. It's safer for breastfeeding and all. Gynecologists do prescribe methyl dopa, and I'm also happy with that. There's no problem. But in puerperium, we usually switch to labetalol. So those drugs are found to be safer and having a good control on blood pressure. Adalat also, we are giving nifedipine also to these, but we restrict it as a third-line drug. Well, it depends upon the baseline reading. See, what I see is you will see the patient in whole. You will see his comorbidities. You will see his physique. You will see his weight. You will see whether his lifestyle, how he is. I feel in this world, like I'm working in UAE, in this part of the world, people are having a sedentary life habits. We tell them a lot to do exercise, but either they don't have time, they fly from Sharjah, Dubai, they are most of the times on road. And when they come exhausted home, they don't get time for the exercise. Their lifestyle is really sedentary. Long journeys and in office desk jobs, on top of that smoking, alcohol is less here, but smoking, which is there. All these patients, if blood pressure is crossing 150, 100 or 160, 100, I prefer to give combination therapy in these patients. And the first and foremost important, we have to see patient, because his compliance is also very important. Most of the times when we prescribe drug and we find the blood pressure has not changed, first thing we have to ask them, I will write patient medicine today, and after 2 months when he comes for prescription refill, he comes sometimes after 3 months, and I tell him, where were you 1 month? uh, Medicine doesn't give birth to children, and how were you? So I often tell them, some days you are smelling the drug, some days you are taking. Poor compliance is really one disaster. Patients doesn't take, and their blood pressure goes in doldrums. So I strongly believe that if blood pressure, it is a person in it's individualized therapy, I may say that it's subjective. Every person is different, but by and large, if a blood pressure is mild, kind of 140/90, 150/90, I start with a single drug, and on return after 1 or 2 months, we'll see how he is. If he's stringently controlled, that's fine, he will continue with that. But if we see that the blood pressure is in doldrums, we will add the medicine, because we want a robust heart and brain and peripheries. Stringent control, 120/80, 130/80 is now the target. Gone are those days when the targets were up. Now we have to have a good strict target for blood pressure. Well, see, all these things are really, they have come up in the recent past only. And I strongly believe that altering the physiology and altering the norms which are set is not healthy for for good. I don't find that they will be like we say that this thing is for good, this thing is for life. I don't feel that, because every now and then something new is coming up, so they are not stable, static. So that's why I don't believe much in that. But sometimes we also, when patient is really stubborn, they are not doing anything, they don't want to do exercise, I also tell them, at least take your dinners early, don't take your dinner late. Although they should have something after 7 o'clock also, that will alter the metabolism, all my circadian rhythms and all. But still, sometimes you get forced, it depends how patient is behaving, and sometimes you get deviated. But I strongly believe that normal physiology should not be interrupted. First thing is, we should have a disaster management. We have, because they don't knock the door disasters. Like we all know that COVID came like a boom, and it had so many emergency things had to come into place. Um, these things will stay. They might not die down. We may forget it, but it will continue like as an influenza is there. So my advice to all future generation or the hospitals as an infection control practitioner is stringent infection control practices. Hand washing has been really amazing in dealing or in prohibiting us from incurring many illnesses, because not only this pandemic, in terms of hospital associated infection, our infection control practices should be stringent, whether it is from a hand washing or it is from what do you call it, etiquettes, cough etiquettes. All these should be in place. All hospitals should have a proper protocol of all these practices, so that they can practice these and will prevent upcoming disasters. And one should have one committee which should deal with the disasters. See, today it was a COVID, tomorrow it can be anything else. This was like a droplet or whatever kind of spread was there in COVID. Tomorrow it can be contact borne. We have to we have to be on toes. We have to keep proper protocols and these in place. There should be one body in the hospital, like who will manage with these disasters. They should have a set protocols. They should have a team leader who will frame how the situation will be handled. Even if there is tomorrow upcoming some food poisoning, disastrous, like we don't have cholera and all here. If such conditions come, travelers, diarrheas, or something which comes up as a disaster, we should have the things to manage it very well. Education, which is first and foremost, it's very important. We have to educate our staff, our society, everyone in terms of that. It has been really challenging. Number one, there is a little marginal difference between a family medicine and internal medicine when it is in terms of dealing with adult population. Only thing is that we experience challenges in dealing with pregnant ladies and pediatric age group, where the first thing the patient should be accepting you as their doctor, because family medicine is a broad term. We are the gateway. We cater all the population from the child to the adult. And it's your patient's satisfaction. And first challenge was that patients would ask me, what is family medicine? How are you different from internal medicine? Basically, it's a primary care physician. It's a concept of UK, US, where the family medicines would only see patients at the beginning. And if they would not be able to manage kind of emergencies or acute medicine, they would refer them to the internist, or they are referring there. He's actually a primary care physician. This is the first point of contact with the patient. It should be first point of contact. Family medicine, family physician is taking care of your all chronic ailments, your hypertension, your diabetes. He's well aware of comorbidities. He has to have a knowledge of wide spectrum, like surgical emergencies, when and how I should refer the patient to the surgeon. Is this the time I can keep him, or I have to refer him now? Because we have a very small, line of where we have to know our limitations, and we have to refer. These are major challenges which we are getting. But alhamdulillah, we have been managing well. We have been doing good. And I will only advise this to keep growing in the knowledge. We need to add to our knowledge day by day. We have to, if we keep on studying more and more, whether it is a degree or a certification, definitely it adds to your knowledge. I remember one of my senior colleague who motivated me rather to do family medicine. She told me that time, it was a really interesting thing. She said that I consider family medicine as a basic degree. It is just after MBBS, everyone should be family physician. And then they should go for specialities, because it gives you when you are doing MBBS, you are doing a graduation. Undergrad, you don't have vast knowledge and experience. You are just a beginner. It is like a child is in kindergarten, then goes to higher secondary, and then goes to university. It is at the, it's at the college, it's at the higher secondary level, where the knowledge is robust, and your experience from kindergarten to that time is also, you are mature by age, you are mature by experience, and you get mature with the knowledge. You try to grab the knowledge very well. It's like you digest the knowledge very well. So then if you choose that you want to go for adult medicine only, now there are super specialties and subspecialties a lot. Now you can go for just acute medicine. You can go for an adult medicine. You can go for internal medicine for subspecialty. I think this is really a great thing, and I also feel same, because it looks like it is like a gateway. It is like you get knowledgeable, and you have a vast knowledge of everything. It's not like when a patient comes to me with acute cholecystitis, refer to surgeon for further evaluation. I don't do that. I don't behave like an impost. I see the patient, I manage the patient, and I refer it once he's going for surgery. So basic degree, it should really come as one should have this degree. It gives you an insight of all the problems. I would have been nothing. I have been dreaming to be a doctor I think since I was very small. I was very passionate to be a doctor, and I still have that passion. I wanted to be a doctor. It's not like many people are like that. They have been pushed towards medicine by parents or somehow, but it was my dream, and Alhamdulillah,
Yeah.
my dream come true.